Hi, my name is Raphael Joseph. I'm a respiratory therapist and a sleep technologist. I'm also a student at George Mason University, completing my master's degree in health informatics. This is my capstone project, Patient Perceptions of Sleep Quality and Outcomes. For my capstone project, I'll be going over 5 lessons: a problem statement, literature review, methodology, analysis, and conclusion. Given the ongoing desire to make healthcare more patient-centered and a growing evidence supporting the provision of patient-centered care, it is important to have valid tools for measuring patient perceptions of health and delivered care. The perception of health via sleep quality is an overlooked area of concern, but it has been falsely related to hours spent in bed. The purpose of this study was to measure patient perception of health from the patient's perspective. Prevalence of sleep apnea increases with age and affects 50 to 70 million Americans of all classes. Obstructive sleep apnea, OSA, is a sleep disorder with a myriad of negative health consequences due to the cessation of breathing while asleep. Having obstructive sleep apnea increases your risk of hypertension, heart attack, stroke, atrial fibrillation, depression, and even death. According to the American Sleep Apnea Association, roughly 22 million Americans suffer from sleep apnea. The National Sleep Foundation has estimated that 26% of adults between the ages of 30 and 70 years have some form of sleep apnea. Currently, the data from the National Center for Biotechnology Information suggests that the prevalence of sleep apnea increases as we get older, increasing from 10 to 17% in men and 3 to 9% in women. From a financial standpoint, the economic impact of untreated OSA costs the U.S. healthcare system approximately $3.4 billion annually due to the condition of being undiagnosed. Patient utilization of medical resources with undiagnosed sleep apnea fell between 23 to 50%. Despite the substantial impact on health and finances, overall self-perception of sleep-related complications generally go untreated and underreported. Self-perceptions to sleep complications are substantial for both older adults and overall American population. An assortment of rationalizations have been examined between internal views of health based on the patient's own health perceptions and external views based on the observation of doctors and/or therapists. One possibility of dissociation of internal-external views is due to the patient's own sensory dampening towards health concerns. This is partly due to the chronic periods of disease development brought on by the fluctuations in weight and poor health educational development. Although all these explanations appear credible, there are a few studies highlighting the correlation between sleep perceptions and sleep-related disorders. A thorough examination of polysomnographic studies among nationwide samples of participants has led to the selection of the Cleveland Family Study. The main reason for the Cleveland Family Study selection was due to the data consisting of 2,284 individuals, 46% African American, and from 361 families studied. Data collection on 4 instances over a period of 16 years. Upon approval from the CFS, the data was thoroughly examined and researched. The CFS incorporated several key data features such as age, race, and more importantly, the apnea-hypopnea index. The CFS patient questionnaires contained pre- and post-polysomnographic study values on the perception of sleep quality and duration. Sleep quality was assessed in patients by the determination of respiratory disturbances, which included apneic events, frequent arousals, as well as oxygen desaturation in sleep. Pulsive sampling was used to explore patients' perceptions and experiences of sleep quality by synthesizing data from the polysomnographic studies across a range of factors. Based on comprehensive research and past experience as a sleep technologist, a structured framework was developed addressing key perception elements and PSG results. These perception elements were selected from patient questionnaires, the brackets containing the symbols, general health rating MSQ1 consisting of a rating system of a 5-point scale where 1 is excellent and 5 is poor. Description of sleep PSG studies DESSLP where 1 is excellent and 4 is poor. Ranking of restorative sleep post PSG study FLSPY where 1 is not at all sleepy, 6 is very sleepy. The ranking of overall sleep quality post PSG study SLPQUA where 1 is extremely refreshing and 6 is not refreshing at all. And finally, the general health ranking SF36_GH consisting of a scale from 0 to 100. Necessary study results were selected based on the overall assessment of the patient's sleep. Several respiratory measurements were incorporated, such as the Respiratory Disturbance Index, RDI, and the Hypopnea Index, AHI, for a given patient in the sample data. The RDI is defined as the combination of apneic and hypopneic events as well as respiratory effort-related arousals per hour. AHI is simply defined as the combination of apneic and hypopneic events per hour. Additionally, measurements that incorporate a desaturation of 3% below baseline during RDI, aka RDI3PA, and AHI, aka AHI3, events were added to the sample. A severity score index was calculated and associated with each AHI, AHI3, RDI3PA, and RDI values. 0 equaling less than 3 events per hour, which is normal. 1 equals 5 to 15 events per hour, which is mild. 2 equals 15 to 30 events per hour, which is moderate. And 3 is equal to greater than 30 events per hour, which is severe. The data was loaded into a SQL database for inspection. The dataset was filtered for consistency along with outliers, negative values. The synthesized sample resulted in 532 patients consisting of 330 male and 202 female, 301 African Americans, 217 European Americans, and 14 other Hispanic, Asian, or count for more than one race. For proper data visualization and ease of producing statistical functions, R was implemented for analysis of the synthesized data. 3 copies of the data have been prepared. In one of the copies, the ordinal variables have been ordered in the R after creating factors. In another copy, used for correlation, the ordinal variables have first been ordered and then have been converted to numeric ones. In the third copy, all the categorical variables have been converted to factors and have been used for ordinal logistic regression. Correlation analysis, only the rows with missing values have been used. The Spearman correlation has been calculated to evaluate whether the perception of sleep quality and health is related to the sleep scoring variables. It can be observed that there was a low to moderate correlation to general health perceptions and sleep quality. There is also negligible correlation between the perception of a good night's sleep post-examination in a polysomnographic study. Additionally, it can be observed that there is modestly negative correlation between the patient's age and the number of respiratory disturbances, RDI, with a 3% decrease in oxygen saturation. It can be observed that overall RDI is normal for those who describe their health as good. The RDI 3PA is worse for those who describe their health as bad. The severity AHI3, i.e. apnea-hypopnea events, increase as the patient's description of own health deteriorates. This can be observed with the increasing percentage of more severe AHI3 categories and worse MSQ1 categories. The AHI values move to more severe categories as the description of patient own health deteriorates. The percentage of patients in better RDI 3PA categories decreases as the description of last night's sleep of patients deteriorates. This can be observed from the decrease in the height of the red bars from categories from 1 to 4 of DESSLP and increase in the height of other bars in the figure below. The percentage of patients in better AHI3 categories decrease as the description of last night's sleep of patients deteriorates. This can be observed from the decrease in height of the red bars in the categories where 1 to 4 of DESLP and increase in the height of the other bars. There is no clear pattern in the AHI versus DESSLP relationship. AHI versus DESSLP relationship appear to be uncorrelated. From the plot, it can be observed that there is an average increase in the best RDI 3PA category percentage if the patient feels sleepier in the morning. There is no clear relationship between AHI3 and FSLPY evident from the plot. There is no clear relationship between AHI and FSLP evident from the plot. From the plot, it can be observed that in general, the value of RDI 3PA moves toward more severe categories as the value of SLPQUA deteriorates. The percentage in worse categories of AHI3 increases as the overall sleep quality deteriorates. The percentage in worse categories of AHI increases as the overall sleep quality deteriorates. It can be observed from the box plot. The General Health Rankings SF36_GH, a scale from 0 to 100, that the severe categories of RDI 3PA, AHI3, and AHI tend to be having lower value of SF36_GH, i.e. lower General Health Value Index. The output shows that the patients with RDI with 30% desaturation based on race, age, sex, and the questionnaire of perception of health, the log odds of being severe to moderate is actually negative n to the first equals negative 6.2801 or 6.2801. There is also a minimal amount of statistical significant variables with a p-value less than 0.05 and a 95% confidence interval. Age, sex equals 1, which is male, severe to moderate RDI 3PA, a moderate to mild RDI 3PA, a mild to normal RDI 3PA, and answering good on the question in general, would you say your health is, has statistical significant value. For patients who answer good towards the question in general, would you say your health is, the odds of being less likely to have an RDI with 3% desaturation is 72%, lower than those patients who did not answer good, holding constant all other variables. As well as for patients who are female, the odds of being less likely to have an RDI with 3% desaturation is 64% lower than those who are male, holding constant all other variables. The output shows that for patients AHI with a 3% desaturation based on race, age, sex, and questionnaire perception of health, the log odds of being severe to moderate is actually negative n to the first equals negative 7.2623 or 7.2623. There is a minimal amount of statistical significant variables with the p-value less than 0.05 and a 95% confidence interval. Significant coefficients include race 2, which is African American, age, sex 1 equals female, and a score of 4 on the question, do you feel sleepy in the morning? Significant intercepts include severe to moderate AHI3, moderate to mild AHI3, and mild to normal AHI3. For patients who scored 4 towards the question, do you feel sleepy this morning? The odds of being less likely to have an AHI with 3% is 55%, lower than those patients who did not answer good, holding constant all other variables. As well as for patients who are female, the odds of being less likely to have an AHI3 with the 3% desaturation is 47% lower than those who are male. Overall, the outcomes highlight the importance of patient-provider engagement in supporting the habits toward healthy sleep. The analysis in general indicates that the patient's ability to assess his or her own health and sleep quality is poor to moderate. Endeavors to bring about sustained healthy habits must incorporate an in-depth discussion about patient sleep perception. It should be predicated on the role of the provider to verify patient sleep perception, as well as providing the necessary tools to overcome comprised sleep behavior. Conceptually, what is important is patient outreach and community education of the signs and symptoms of inadequate sleep. Thank you.